Food for Thought with Professor David Ndetey.
It's another beautiful day. How are you doing? Thank you for tuning in. It's Food for Thought with Professor Ndetey. It's the fourth part of a four-part series that we began 3 weeks ago talking about borderline personality disorder. I'm sure you've learned quite a number of things about this disorder. And if you have a family member or a friend that is exhibiting some of the traits we are talking about, my friend, reach out and get them the help that they need. That is why we are doing this segment of the show, to educate you and I about mental health issues. So today we wrap up this conversation. There's still a couple of things we need to talk about. Let's pick up this conversation from where we left off last week. How do you manage such a person?
Well,
thinking that probably if their case is not that extreme to the levels of 8, 9, or 10, if they're somewhere in between there, how do you manage such a person?
Well, if I may put it this way, you just can't. I just can't say. I just can't go and say, you so and so. I think you have a problem. As a doctor, I cannot say that.
Yeah.
And I cannot say you need to be treated. Okay. You must go to hospital. You cannot do that. I may be somebody here on the streets, and there are very many of them. And as you drive, you say, well, that person is suffering from schizophrenia.
Yeah.
And it's so obvious, maybe to me as a psychiatrist, but I just can't go and say, hey, go for treatment.
Yeah.
You can't do that. And sometimes they are protected by law. If you go to San Francisco,
yes,
it has got the highest number of people living on the streets.
Really?
Yes. A leading city with people living on the streets. When I first went there with colleagues, I was asking them, what's the matter? There are so many people on the streets. He said, yes, we know they have mental illness, but you cannot touch them unless they break the law.
Oh, okay.
Yes, you can't touch them unless they break the law. How is behavior? How is living on the streets affecting you as a person? Or how has it affected anybody else as a person?
Yeah.
It is your right. So in other words, it's not just the severity that makes you gives you the justification to intervene, is whether somebody makes a request. Yeah. It can be that person who says, I think I have a problem, can we talk about it?
Yeah.
Or more often than not, is somebody else who comes and tells, says, I have a friend, he or she seems to have a problem, and I just want to help because it's affecting maybe the relationship between him and I, or I can see it is affecting his job. But more often than not is the relatives who live with this person who say, we can't take it
anymore. Okay.
Please help us. The person who comes along, the patient, may say, yes, I need some help. But more often than not, they say, no, I don't have the help. It's the one they are the ones who are the problem. They are the one who are treating me badly. They are not kind to me, and so on and so on. So when you intervene, you intervene only when there is a request from somewhere. Either the patient himself, or a friend, or a relative, or sometimes the employer who says, we have this kind of person, we think there's a problem, we don't understand this person, can you really help us understand this person? That's how they get into treatment.
Wow.
So,
okay.
Yeah. When they get to treatment, then there are various ways of treating them. And the most important one is history.
Okay.
And the history the most important person to provide that history is not the patient himself or herself. It is somebody who knows that person very well.
Okay.
And has known that person for a long, long time. And they will be able to tell you how it started, what it is that.
So the history is basically their behavior.
The history is the most diagnostic tool. Yeah. You know, I remember Dr. James McDougall, he's now in his 80s, late 90s, when he was used to teach us here in the medical school, he used to tell us, when you are taking history, listen, and listen, and listen, because whoever giving you the history
Yes.
is giving you the diagnosis. Like taking the history is like going to a laboratory. They take blood from you, and then they go and do lots and lots of tests, and they tell you this is where the problem is. We don't do that in psychiatry. We take very good history. Even in medicine, you have to take very good history.
Yeah.
You take very good history from the people who know this person very well, and eventually you also include the patient. What do you say about this has been said, and then in the process, you establish a dialogue.
Okay. But before we get a little bit more detail about the treatment, I'm just wondering, is there a particular kind of age group where this manifests a lot?
Yes. And it begins to, as I said, very early in life. Because I said it is a pervasive condition.
Yes.
But it tends to manifest mostly in adolescence and early adulthood. Because that is when people are trying to find their place in society, their emotional identity. No wonder sometimes they call it adolescent crisis, that kind of behavior. I mean, we have heard about that story.
Yes.
It revolves around that way. So that's where we tend to see it most. So most of the people that I see here, and I'm sure the same with the other psychiatrists, it tends to occur in young people.
Young people.
Yeah.
Okay.
Yeah.
So talk to us a little bit more about the treatment. What
The
does that
treatment, as I
entail?
said, history is very, very important because you'll be able to get to know the diagnosis. You'll be able to know that this person, because of the history, this problem has been going on for a long time. We are most likely dealing with a personality disorder.
Yeah.
Because they will not come and say, Doctor, I have borderline personality. They will not say that.
No, they don't even know.
They don't even know.
Yeah.
That's right.
Yeah.
They don't even know. So by taking that history, you can say from the history, I'm dealing with a personality disorder. What kind of personality disorder I'm talking about? And then let's assume that eventually it is borderline personality disorder.
Yeah.
This person, as we said, and we have been talking about comorbidity, they may have a mood disorder, a manic disorder. They may have either manic phase or depressive phase, which is when they get depressed, please don't get surprised. Because they have all of these problems. They know something is not going on right. There's something wrong, either with them or with the people around them or with the environment. They are very stressed. Yeah, who will not get stressed if they go through all those problems, the relational problems? So, getting depressed by a person who has gone through all of those issues is actually understandable, or even anxious, and so on and so on. So, you want to unravel any comorbidity that is existing.
Yes.
And you treat the comorbidity, if it's depression, whatever it is, you treat it. And assuming that that is now those other surrounding or condition are taken care of, then you can focus on your borderline disorder.
Okay.
And that's where the problem is, because these people are not easy to treat.
Why?
Well, they are not easy to treat because there is no medicine that you can give.
Oh.
If you are dealing with depression, if there is depression that's related to that personality disorder, if there is an obvious psychiatric disorder for which we have medicine, then you can treat those. More often than not, they tend to improve because you have, if you treat the depression, for example, you will have removed a complicating factor.
Yeah.
So once you've taken those things out of the way, and then you are just left with a borderline disorder,
Yeah.
and that is the only thing that you are dealing with, then it's not easy because there's no medication for that. But then there are ways that can be used to treat this condition. One of them is what we call cognitive behavior. They are forms of psychotherapy. You are not giving medicine, but you are talking. They call it talking therapy.
Yeah.
You first of all, you want them to understand their condition, because most of the time they really don't understand what's going on in their lives, and you tell them, I think this is what is happening.
Yes.
Or you ask them the question, do you think there's anything the matter with you? Probably after taking that kind of history, which may take up to about 1 hour or so, then they will begin to realize that they have there's an issue here.
Yeah.
And then you ask them, what do you think the issue is? They will tell you, I do not know. And then you explain. So getting the person to understand his or her problem is very, very important. And this is not only in psychiatry, it's in every condition. Whether you are dealing with a malignancy, that is cancer, what kind of cancer is this? What could have happened if it's diabetes or whatever you are dealing with.
Yes.
Patients need to be educated about their own conditions.
Yeah.
That's very important. So creating awareness not only in the relatives, for them to understand that this is not a difficult patient, a difficult person. This person has got issues which they have no control over. It's not their fault. It's a very important treatment. And also, at this point, even before we focus on the individual, you are talking about treating the whole family.
Oh.
Yes, you are talking about treating the whole family, because if I have a problem, and you are my father, it will have caused problems between you two. So the father also is a patient. That family is also, they are patients. So getting their relatives to understand what is going on and improve that kind of relationship. You see, we call it family therapy. It's like you are bringing them together to talk about this person. And then in that way, you remove the negative connotations between the negative communication between these two people. If, for example, if I have a pen, I can say, and maybe I've given you this example before. I'm holding a pen. I can say, call me David. David, give me that pen. You can say, give me that pen. Forwards. Give me that pen. But the way you say it is going to have very different implication. If you say, give me that pen, I'll give you that pen, because you have asked in a normal way. But if you say, give me that pen, as if you are going to fight, my reaction will be very different. Maybe I'll give you the pen, but I'll be left frightened. And that's going to affect me. Or if I go on my knees and say, give me that pen, I'll give you the pen, but you have to go on your knees. We call it expressed emotions. And it's a very important dynamic in the family relationship. Just the way they talk. Okay? But the parents will come and say, this person, this son of mine, this and that and that. And, you know, the father will say, I don't want even to see you. It does not help.
Thank you so much for watching. I hope that the information we've been giving you as we've talked about borderline personality disorder has been beneficial to you. Once again, if there are any mental health issues you would want us to discuss with Professor Ndetey, feel free to suggest. Our SMS line is 20316 and our WhatsApp number is 0786 316 316. Have yourselves a great day and God bless you.
Food for Thought with Professor David Ndetey.